Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
These are my disclosures. So we're going to talk about expedited partner therapy. I think you all know this, but I just want to make sure that we're all on the same page. So expedited partner therapy is a term that means the written prescription of STI treatment to the partners of a patient with an STI. This means that you're writing a prescription without examining the sex partner, which is usually a no-no in medicine, right? We don't take care of patients that we're not actually seeing. But it has been made permissible in most states around the country. This graph, I put this on here and then I went and checked the CDC website. It's actually been updated. It's no longer prohibited in South Carolina. It is actually permissible, and they're just the 4 states where it is potentially allowable. And you would need to go to the CDC website to look for your own state and any particular guidance. And it is effective at reducing reinfection in the index patient, the patient that you were originally seeing for sexually transmitted infection, for gonorrhea and chlamydia. So just to review a little bit of the evidence for the effectiveness, this was a meta-analysis that was conducted in around 2014 of the major randomized controlled trials that looked at EPT being used in the form of kind of partner packs, whereby the patient takes the medications. In all of the cases for chlamydia, it was azithromycin. All the cases for gonorrhea, it was either cefixime or cefpodoxime plus azithromycin for chlamydia treatment, unless the chlamydia had been ruled out in the index patient. And in the meta-analysis, in the pooled studies, we see that combining gonorrhea and chlamydia, there was a decrease of 40% reinfection rate in the index patient. However, if you look at chlamydia alone, it doesn't actually meet statistical significance, but it does decrease the risk by about 10%. So there are some caveats to this data for the implementation in 2022. The trials that this is all from were conducted, as you can see, in 2003, 2005. The landscape of STIs is a little bit different now, right? This early 2000s, we didn't have any azithromycin-resistant gonorrhea. We didn't have reduced susceptibility cephalosporins for the most part. And we didn't have the understanding of the difference between doxy and azithro for rectal chlamydia, or the high proportion of rectal co-infection of chlamydia among cisgender women who have vaginal infections. These studies also were only studied in cisgender heterosexual individuals. And as I said earlier, the treatment regimens were primarily azithromycin for chlamydia, and gonorrhea was cefixime 400 plus 1 gram of azithromycin. So the 2021 treatment guidelines had some updates for the EPT guidance. Consistent with the new treatment recommendations or preferred treatment recommendations for chlamydia was to use doxycycline 100 milligrams twice daily for 7 days, also for expedited partner therapy. For gonorrhea, they recommended using cefixime at 800 milligrams given once. And if you cannot exclude chlamydia, then add doxycycline. And then a population that had been recommended against giving EPT to was men who have sex with men. And in 2021, they updated the language to say you could use shared decision-making. So I'm going to walk through a little bit of the evidence for why these changes were made. First, the change to chlamydia treatment is based on some randomized controlled trials about doxy efficacy being superior to azithromycin, particularly for rectal chlamydial infection. So this is a trial that Julia Dombrowski completed at 2 sites in the U.S. They enrolled, the evaluable population was 177 men who have sex with men with rectal chlamydia who were treated either with doxycycline or azithro. And you can see here in this graph, they had a couple different case definitions, but regardless of the population, there was a significant risk difference with doxycycline being superior in all cases. Somewhat similarly, there was an RCT conducted in juvenile detention centers where directly observed therapy was insured, as well as mostly insured, and probably, I don't think they probably could 100% control for this, that there was no risk of reinfection, where they randomized youth with urogenital chlamydia to receive either doxy or azithromycin. And they observed no treatment failures in the doxy group, but they did observe 5 in the azithromycin group, making the difference of doxy 100% effective to azithromycin 97% effective. However, this did not really reach the statistical significance to make azithromycin inferior, so it was not non-inferior. But there is probably a slight benefit to doxy over azithromycin for urogenital as well. There's another reason that the CDC changed the chlamydia treatment regimen, and that is kind of bystander effect, right? So the azithromycin has some unique kind of pharmacokinetic properties that have predisposed it to creating resistance in many bacterial species. So within the STD field, we're most concerned about azithromycin-resistant Neisseria gonorrhea, which in 2018, the graph we're looking at here from the gonococcal isolate surveillance project, consists about 5% of the surveilled isolates. But when we look at that by different populations among men who have sex with men, it was about 10%, and there was a stark difference there. Now, the World Health Organization, the CDC, have had kind of a standard guidance that for any recommended therapy, if there's more than 5% resistance kind of circulating, that therapy needs to be removed from the guidelines. And so azithromycin was removed from gonorrhea treatment guidelines, but in terms of antimicrobial stewardship, it was thought that azithromycin should probably not be used quite as much also for chlamydial and NGU and trying to be consistent. And this is also a problem with another STI, Mycoplasma genitalium, which I'm not going to get into today, but that was also part of the rationale. So what's the rationale for changing the gonorrhea treatment regimen? And much of this is just to be consistent with the guidelines for the first line recommended GC treatment, which is ceftriaxone, right? So the main guidelines recommended an increase in the ceftriaxone dose and removing the azithromycin resistance. And part of that is because of the resistance. The other reasons to increase the dose was a new understanding of the pharmacokinetics and pharmacodynamics of ceftriaxone and the gonococcus, and an understanding of the mutant prevention concentration, which is this idea that not only do you need to kind of go have a dose that is higher than that would get you kind of a cure, but you need to also be able to prevent the escape of mutants in a heterogeneous population. So when we look specifically at ceftriaxone PK/PD, there's basically been 2 newer studies that tried to estimate the time over the MIC, which is the predictor for beta-lactams. And that in the mathematical model, it seemed to be about 20 hours of time. And in the mouse model, it was about 24. So 20 to 24. So here at this little chart, we're looking at the old ceftriaxone dose, which was 250 milligrams. And you can see that while at the MIC 90, which is what 90% of the circulating gonococcal isolates MIC is 0.03. The median time over the minimal inhibitory concentration is about 40 hours, which seems like it should be fine, and it does work in the vast majority of cases. However, if you look at the 95% confidence interval, you see that the lower bound is down to about 20 or just under 20. And that is somewhat concerning, and we know from understandings of pharmacokinetics that this wide confidence interval really corresponds to this very variable interindividual pharmacokinetics. So some people seem to kind of metabolize faster and some people metabolize a little bit slower with their ceftriaxone. And so it's not 100% guaranteed that we're going to eradicate it. And the caveat to this data is that this was based on urogenital infections and not pharyngeal infections. And we don't actually know what time over the MIC is needed for pharyngeal infections. So in looking at the 500 milligram dose, we were thinking, one, if you look at the 0.03, that gets you about 10 more hours at the median time over the MIC, and then predicting the future, because these guidelines take 5 to 6 years to come out, that maybe the MICs are going to start going up. It may protect against futures, elevated MICs. So extrapolating that to the EPT regimen, we have a little bit of data from those 2 models. The math model says, it's about the same time, but the mouse model actually says cefixime needs significantly longer time over the minimal inhibitory concentration, which is like 40 hours. We don't have a great understanding of the time over the MIC for cefixime, but we know at the 400 milligram dose, it's about 26 hours. 800 milligrams, we're not entirely sure, but we expect it to be longer. And then comparing that with the clinical data, it does seem that the 800 milligram dose is going to be good for urogenital infections, although I do have some concerns about pharyngeal infections, particularly when used alone, because although small numbers, not as effective. And what about the evidence for EPT in men who have sex with men? The evidence remains limited. There's been one RCT that compared EPT to passive partner notification in Peru. And the outcome wasn't efficacy on reinfection, but was just increasing frequency of partner notification. It did seem to do that, which is great, but there's no data on the risk of reinfection. So putting this all together, what are some things we need to think about when considering EPT and the new recommendations? I think for chlamydia, there are many in the field who are concerned that doxy has more potential side effects compared to azithromycin, including photosensitivity, piloesophagitis, teratogenicity in pregnancy. And, EPT has this, you're not seeing the patient, you're not able to counsel the patient. And so I think there's a lot of clinicians who are very concerned about using doxycycline for EPT. Moreover, there's actually no studies of doxy for EPT. So there's concerns about adherence. There's concerns about the ability to assess for pregnancy or to counsel. With gonorrhea, there's limited efficacy at the pharynx, and we know that pharyngeal gonorrhea can be present in about 20 to 40% of heterosexual contacts to gonorrhea, which is not insignificant because these are the exact people that we would be giving this regimen to. And then the use of EPT in MSM, again, there's very limited data. Pharyngeal GC is common, so the same issues with the gonorrhea treatment regimen apply there. Looks like antimicrobial resistance for gonorrhea is higher among men who have sex with men. And then there's also, which was one of the kind of prohibitive reasons for using EPT among men who have sex with men prior to the 2021 guidelines, is that MSM presenting with chlamydia and gonorrhea have a higher prevalence of co-infection with syphilis and HIV. And if they're not coming in for testing and treatment after exposure, then we are have the potential to miss those diagnoses. Hillary mentioned that I have a couple of different hats. I want to be very explicit that I'm wearing my Public Health Seattle King County hat at the moment and let you know what we're doing with our EPT recommendations for King County. For chlamydia, we are continuing to use azithromycin, especially if this is not with use of a partner pack, for the cisgender female partners of cis men. And, either doxy or azithro would be appropriate for male partners if some form of counseling or paperwork could go with that, or counseling from the pharmacist. For gonorrhea, we are actually recommending to combine cefixime 800 milligrams plus 2 grams of azithromycin. And you can separate the azithromycin 2 grams into 1 gram at the time of the cefixime and 1 gram 12 hours later. And this is because of the concern for pharyngeal gonorrhea and the new data that we're seeing that 20 to 40% of cisgender heterosexuals are going to be positive at the throat. And we know that 2 grams of azithromycin is better, and the combination, although we don't have empiric data, we believe this combination will kind of cover both the risk for chlamydia, the risk for pharyngeal gonorrhea, as well as urogenital. For men who have sex with men, the ideal situation, again, is to have the patients notify their partners to come in for testing and treatment. If that's not possible, or in certain situations, you and your patient can use shared decision-making. So there have been a handful of studies that have looked at some of the barriers to EPT use. This was a study done by a gynecologic group that looked at using EPT with pharmacists, and they did a survey of pharmacists. So when they asked pharmacists about their knowledge, about 23% knew what EPT was, and only about 14% had ever received a prescription for EPT. And I believe I'm now forgetting where this group is, but they're outside of Washington State. Of those who had received EPT prescriptions, they would fill an EPT for someone who was under 18. And then they did some counseling, and after the call, a pharmacist would fill prescriptions for EPT, which is great.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.